This is Audible Bleeding, the Vascular Surgery Podcast. We're here to help you keep your finger on the pulse.
Welcome to Audible Bleeding. We are doing a special episode on spine exposure. We are here at the hospital for special surgery today.
This is Kevin, and I'm going to give you an introduction of our esteemed guest today. First up, we have Dr. Todd Albert. He's the Surgeon-in-Chief, the Chief Medical Officer, and the Korein-Wilson Professor of Orthopedic Surgery at Hospital for Special Surgery. He's the Chairman of the Department of Orthopedic Surgery and a Professor of Orthopedic Surgery at Weill Cornell Medical College. Dr. Albert is the author of 7 books and more than 40 book chapters and has published over 375 peer-reviewed and non-peer-reviewed articles. We also have Dr. Sheeraz Qureshi. He's an associate attending orthopedic surgeon at Hospital for Special Surgery and associate professor of orthopedic surgery at Weill Cornell Medical College. Dr. Qureshi is a recognized leader and one of the premier surgeons in the field of minimally invasive and motion-sparing spine surgery. Dr. Qureshi has one of the busiest clinical practices in the country, performing nearly 300 minimally invasive spine surgeries annually. We also are lucky enough to have 2 of my vascular mentors and attendings, Dr. Dr.Ellozy, who many of you know is Associate Professor of Clinical Surgery in the Division of Vascular and Endovascular Surgery at Weill Cornell Medical College and Associate Attending Surgeon at New York Presbyterian Weill Cornell Medical Center. Dr. Ellozy is also the Program Director for the Vascular Surgery Fellowship. And lastly, not least, Dr. Peter Connolly is an Assistant Professor of Surgery in the Division of Vascular and Endovascular Surgery at Weill Cornell Medical College and an assistant attending surgeon at New York Presbyterian Weill Cornell Medical Center. Welcome everyone to Audible Bleeding, and we are excited to learn about spine exposures and how vascular surgeons and orthopedic surgeons can collaborate for the betterment of our patients. Dr. Albert, we'll start with you. As we talked before, our audience is largely vascular surgeons, some that have significant experience with this approach with spine exposures, but many who do not. Can you just give us a brief overview of who are these patients that we're treating with, and then what kind of the spine exposures that you have in your repertoire?
Sure. Thanks for having us, first of all. The people that we usually ask our vascular colleagues to help us with exposures on, and we're very lucky to have them, are patients with deformity, a slippage of one vertebrae and another, often called a spondylolisthesis, and if we're going to approach it anteriorly, or scoliosis, where they have a deformity where their spine is collapsed and they get rotational deformities. And if we go anteriorly, we can get better correction of the spine, more to the native-looking spine, improve their curvature, etc. And the other reason we use vascular exposures are if we have tumors or trauma where we need to expose the spine anteriorly, as well as degenerative disease. A disc is worn out, herniated in a way that we want to take it out from the front, and we think it's safer. And in some ways, while it isn't minimally invasive, it can be less invasive because we don't violate their posterior musculature. So something I've done quite a bit is use anterior standalone devices in the front of the spine. And to do so, I need my colleagues to expose L5-S1, which I know is a little bit of an easier exposure for them, but at times L4-5, which can be challenging, I think, to get the entire exposure we need.
One term as a general surgeon that we have very little exposure to orthopedics in our training is the term fusion. Can you describe why does a fusion help these patients' back problems, and what determines a successful fusion in the long term?
Sure. So one of the reasons is whether it's absolute instability, meaning motion when they flex or extend or move side to side, or an implied instability. The disc is completely collapsed and the nerves are getting crushed, or the disc is very degenerated and just motion around the disc induces pain. So a fusion helps them for a few reasons. One, if you can elevate the disc height back, you're indirectly decompressing the nerve and nervous structure, that helps. Stopping the motion stops the irritation. So just think of a fusion as a welding together of, let's just say, L5 and S1, or L4, L5, the two vertebrae. And how do we, I think you asked how we measure it or how we know something's fused. We can tell both by X-ray and or CAT scan, looking if we put cages in, we see if there's bone grown across the interspace, or if there's no motion in flexion extension X-rays that we take.
And the term cage refers to the disc that you place?
The device we put in. There are artificial discs, which we also have put in the spine, much more kind of frequently now in the neck than the low back, because they didn't work out as well in the low back in terms of pain relief as a cage. And a cage is like a strut that has it's a rectangular usually, or it can be round, but it has a hole or opening in the middle where we put either a pharmaceutical device, a little sponge that makes bone grow.
So how do you decide between the different approaches for fusion? You know, we hear a lot of acronyms: ALIF, PLIF, TLIF, XLIF.
So, thanks guys for having us. And I think it's an important conversation. So, I think as Dr. Albert was mentioning, spine surgery works best when we're doing it for decompressing neural elements or for reconstructing a spinal deformity. And so the term fusion, which is something that we're trying to accomplish, really is often a necessity to accomplish one of those goals. If we can accomplish either of those goals without doing a fusion, then that's always our preference. But oftentimes, because of what's happening with the spine and the cause of those problems, we have to restore that structure or increase space, and so we have to perform a fusion. So when we want to do a fusion, we can do it anteriorly, which is referred to as an ALIF. We can do it posteriorly, which is referred to as a PLIF or sometimes a TLIF, or we could do it through a direct lateral approach, which is most commonly called an XLIF, and then more recently an oblique lateral approach, which is called an OLIF. I think the purpose of sort of which direction we're coming from, they all have their advantages and disadvantages. So specific to ALIF, I think the biggest advantage, like Dr. Albert mentioned, is that it does follow all the principles of a minimally invasive approach, especially when it's done through a retroperitoneal exposure, because we're following tissue planes and we're not cutting muscle. And then from a spine surgeon's perspective, it allows for the placement of the largest graft that can come in different shapes and sizes. The reason we can't do that posteriorly is because we just don't have the space to work around the neural elements. Whereas when we come anteriorly, we don't have to worry about that. And so we can really fit the type of graft that we want in terms of width and depth and height much more easily and safely. Sometimes it's not an option to do an ALIF either because of the level of the spine that we're working on, most commonly because we don't have access to good exposure surgeons like we are lucky enough to have. And then other times when it's in combination with something where there's spinal stenosis and we need to not only rely on the indirect decompression, but we want to directly decompress. So that's where we start to think about sort of what is the goal of our surgery, what are we trying to accomplish, and what is going to be the easiest way to accomplish all of the goals.
Great. If we can take one step back, and I know you did an entire residency and fellowship to determine this, but could you give me like a 30-second explanation of the classic patient and kind of the objective findings that say this patient qualifies and needs spine surgery?
Okay, so that's a tough one but I would say that, spine surgery, again, works best when there's some sort of a neurologic compression. And in the lumbar spine specifically, when we think about it, that comes as either spinal stenosis or herniated discs. So who needs spine surgery? A patient that has difficulty, not just with back pain, but really with pain in their lower extremities, either one or both, which gets worse with activities and has the findings of some nerve tension signs that has failed non-surgical management. Maybe we should just ask Dr. Albert to make sure that he agrees with that and that I haven't missed anything.
I think that's true. That and or who does best with spine surgery is neural compression, trauma, tumor. Those are the things that, trauma, tumor, you generally have to operate. Neural compression, actually the majority of people with neural compression can get better without surgery. So we should add one thing to the neural compression. Neural compression in the face of failing non-operative treatment. Because the majority of patients in spine, we really try to treat non-operatively. There's few absolute indications for spinal surgery because people can limp along with what they have, but when they have a bowel or bladder problem, emergency. Or if they're getting progressive weakness, it's a relative indication. It's not an absolute indication, but that's somebody we go usually earlier.
Great. I think that was a fantastic overview to kind of set the stage. So as a vascular surgeon, we come in there and we're going to do a retroperitoneal exposure, and we'll just kind of say for L5-S1 for the simplicity of discussion, how much do you need to see, and what are ways that vascular surgeons can do this to better help you?
Okay, I'm going to answer because I'm the most selfish in the sense of I would like to see from almost, if you look at it like a clock, I want to see from 12:30 until 11:45. That's and the two doctors sitting across from me know, but the truth is they deliver, because I want to be able to come in if I'm doing, I'll just say an ALIF, an anterior lumbar interbody fusion with a cage at L5-S1. I want to be able to come in. I want them to place the retractors. I want to be able to take my scalpel and do a largest cut from side to side on the annulus, the covering of the disc, and then sequentially take a Cobb sharp instrument and take the disc off the end plate side to side and evacuate the entire disc and then slam in this graft. And if the doctors, the vascular surgeons expose that in that way to me, I feel completely safe. I won't tell you after doing this for 25 years, I haven't ever hit a vein. I feel terrible and it's usually, honestly, not the vascular surgeon's fault. It is my fault because I come in and the vein is hanging over and I don't ask the vascular surgeon to say, can you fix the retractor for me? Or I don't fix the retractor or whatever. That's every time I've had a vein injury is generally I'm using a sharp instrument. I'm not under as much control as I should be, and I slip with a curette and get it, but it was there, and it didn't have to be there because I know from having worked with them, they place the retractors. It's not usually possible to do that. So that's a really, I think, important one. I don't know if Sheeraz is.
Yeah, so I think some of it, I would agree with everything that Dr. Albert just said. I do think that you want to ask the surgeon, the spine surgeon, what kind of surgery in terms of what kind of device they're going to be using, because sometimes that can make a difference in the exposure. So if a spine surgeon is going to put a plate on the front of the spine, even if it's a single level surgery, then they may want a little bit more proximal and distal exposure. If a disc replacement is being done in the lumbar spine, you often want a little bit of a wider exposure, and it's really very important to know exactly where the center of your disc space is. It's important in fusions as well, but probably more in disc replacement. So sometimes the type of device that we're using to achieve either a fusion or a replacement can dictate the amount of exposure we need. But like Dr. Albert said, the wider, the better, and sort of when nothing is in the way, that's ideal.
How often do you guys use a plate in the lumbar spine? Because I've run into issues where if something is proud on the vertebral body, it can, we get the vessels out of the way, but when you let them fall back into place, sometimes you can have some tension on the vessels from that,
Yeah, it's rare, I think, for us to use it. What we use more commonly are devices, as you've seen. Technically, it's a plate on the front of our cage, but it's almost part of the cage, and then we put screws through the cage up into the vertebral bodies, up into 5, down into S1 if we're doing that level. So it's more through the device.
Dr. Albert, one thing that Dr. Qureshi was telling us is that you actually you helped develop many of the technologies that we have now as far as the lumbar fusions go. We're wondering if you could give us a short kind of historical perspective on kind of where we've come with fusions of the lumbar spine.
Well, sure. Thank you. Yeah, I think Dr. Qureshi gives me too much credit, but I'm appreciative. Somebody once told me that it's the mark of a friend that will lie for you. So, it's easy to tell the truth. Anybody can lie. Only the friend can lie. But so we've evolved from using where we didn't have artificial devices in the front of the spine. All we had was we would take allograft, either femoral ring allograft, and carpenter it ourselves with saws and make it so we could put it in. And we start by putting a screw and a washer in. I hate doing that now because actually in my past life, I'd seen a case where somebody did that and it backed out and the patient ended up dying because the revision approach was so hard that they got an ischemic leg and ended up dying. So the devices, so we went from that to pre-contoured allograft where they were fit in the same way with different degrees of angle, lordosis, to another thing that was a really good advance was special devices to deliver whatever your interbody cage is, where you would put, as you put the cage through, it would distract the inner space. So it delivered it very gently in a sense instead of pounding on it to get it in. And the next iteration of the interbody devices was for fusion, and then we'll talk about disc replacement in a minute, but for fusion were these, what we call a cage. And it started with metal cages that we developed. They were titanium. And they were titanium and they had different shapes and sizes. And that was a big advance because you could have different widths, different depths, different heights, different angles. Then they started experimenting with different materials, PEEK, carbon reinforced PEEK, and just different devices that became radiolucent, which is nice because, as I said before, you said, how do you know if it's fused? If the device is radiolucent, you can see when bone has grown across. It's easier. We're now going back to this PEEK with titanium and different kinds of cages that are all very useful. And then there was a whole era of disc replacement with the idea of trying to maintain motion instead of doing a fusion for your interbody device. And the reason I think that they were less successful than fusion has been is many of the pathologies for which we do these interventions are pain related to the disc being compressed and being collapsed. And when you leave it moving, sometimes the joints, which are called facet joints in the back, can become arthritic and cause pain. Or more importantly, you're not really sure of the pain generator. And if you put an artificial disc device in and keep the motion going, you may be accentuating the pain as opposed to relieving the pain.
What's the time period of the development from, homemade femoral ring allografts to sort of the current devices? I mean, if you look at heart valves, from the earliest valves to like the Edwards valve, it's probably been about 20 years. Stent grafts, we've been doing them now. Like it's taken a couple of decades to really go from the homemade devices to what we have now, which is really sort of third generation stuff.
So the homemade devices were in the late 80s, early 90s, to the modern devices being to early 2000s to now. They've become more sophisticated in the last, I think, 7 years. Do you agree? 8 years.
Yeah, so I would add to that I think what's happening now is that there's more of a focus on the surface technology. So we're trying to see whether or not the material that we use can actually help the fusion, whereas in the past, with PEEK especially, which we used for a long time, it was really just a housing, and then we would use a product called Infuse that we would put inside of the cage, but then that product came under some controversy, even though I think the majority of us still use it and believe in it. But now we're starting to think about whether there are certain types of metals that we can think about attracting bone formation.
So on this topic, part of the reason here today collaborating is to discuss why it is important that spine surgeons and access surgeons discuss these cases and collaborate beforehand. Can you discuss how a good relationship with an access surgeon improves your guys' ability to provide good care for your patients?
I think I've viewed it over the years as critical because, first of all, it is an area where I trained, we worked with access surgeons, but when I started, I did my own access. And for me, it was much more stressful, to be honest with you, than have somebody that's doing it all the time, every day. They're helping to gain access. So having done both, I much prefer working with really, really good access surgeons. Plus, you sometimes get into problems that you could have never anticipated or never seen. And I think it's really helpful to have your partners who are doing this every day. They're not just, I don't want to say it's the easiest thing you guys do, but it's not the same as taking somebody's, abdominal or aortic aneurysm and taking apart their whole aorta and putting it back. In my opinion, this is probably not as complicated for you. And so I like that's their thing, and our thing is, reconstructing the spine.
Has collaborating with a access surgeon before a case ever changed your approach, whether it's the patient's surgical history or it's a revision or something that the discussion before surgery changed how you treated the patient?
Well, yes, and I'll tell you the opposite. That I had a patient who had gone all around the country looking for a way to fix it was an isthmic spondylolisthesis. It was adult. And they came and I said, I have an idea. We can do it from the front and just do a single approach through the front, and we'll do a gauge. And one access surgeon had said, no, it can't be done. And I called your boss, Dr. Connolly. He said, can I see the films? He saw the patient. He said, I can do that. And I'm like, terrific, because I think this guy will be really happy. And he did the exposure for me. We did the case. It wasn't the simplest access, but he did it without too much sweat. And the guy was so happy. He went back to playing soccer, doing all these things, downhill skiing. And he would have otherwise gotten an approach that, it would have worked, but it would have been far less successful. So I don't think it's exactly what you're talking about, but it was access where I said, I have faith in a guy. I think he could do it. And other people said it couldn't be done. So.
Thank you, Dr. Albert and Dr. Qureshi, for helping explain to us the fundamentals of spine surgery.
Okay, and now we're going to hear the vascular surgery perspective on exposing the spine. Dr. Ellozy, take it away.
All right, so Peter, I think that the two levels that we're most commonly called to expose these days are L5S1 and L4L5. I think that that's really what they get us involved in from an anterior approach. So what are the important steps for you for both these levels? Like, we'll start with L5S1 and then go to L4L5 in terms of anatomic landmarks and steps of the procedure.
So for the L5S1 exposure, probably the most salient features are obviously whether or not the patient's had any prior surgical background, and one of the prior surgeries where you can get into trouble is, and it seems kind of, most patients don't even think about it when you ask them if they've ever had any abdominal surgeries, is an inguinal hernia repair. And so it's similar to, as we learned in general surgery, when you're doing a laparoscopic hernia repair, you're basically trying to get into the same plane. So the way I approach it is, if I'm doing a single level L5S1, I do it via a low fan and steel type incision, and I'll usually approach it from the left side. So the left side anterior rectus sheath is incised, and then the rectus muscle is mobilized medially. Then I'm down basically into the left lower quadrant, and I can continue it's all a blunt dissection, dissecting the retroperitoneum and peritoneum, cephalad to the patient's right side, until I'm ultimately right on top of the iliac artery. When I can either visualize the psoas or feel the iliac artery, I'm usually in a pretty safe plane. And then it's just a matter of continuing your dissection along that medial border of the iliac artery until you can palpate with your finger the L5S1 disc space and bony landmarks. retractor systems that people decide they want to use for these approaches I think is very important. You have to be comfortable with the retractor system. The retractor system I use most frequently is what we call the syn frame or the Synthes frame, and I think the best benefit to this is the blades are rather stiff. It's an O-ring fixed retractor system, and it's fixed to the table in two positions, and the narrow blades allow for an excellent exposure to a disc, so you don't get overwhelmed with lots of different retractor arms and pieces sticking in your way. Generally, you don't have to use a handheld assist device, and it can function almost completely independently once you get it set up well.
Have you used any other systems? Like I've used the syn frame is probably my go-to retractor, but some of the spine surgeons have different preferences. Like Qureshi really likes to use the radiolucent Thompson, and so I've used that. And they've got they've got a brow blade, which is a reverse lip blade, which is sort of nice to slide around the opposite side of the vertebral body because it stays in place. Have you used any of the other systems?
I've used the Invasive system. I mean, but they're all pretty much the same type of thing. But I agree. You know, if you have a one of the fallback options, I guess, is another option with the Synthes frame is they do have radiolucent retractors, but they tend to be a little more flexible.
Yeah. With the syn frame and the radiolucent blades, what I like to do is get all the exposure with the regular blades, and then once it's locked in, then I'll switch out for the radiolucent blades at the end. And so that you need a little bit more stiffness to get there, but once it's fully exposed, the radiolucent blades are often enough to hold it in place. And I'll usually use the blades just for the lateral blades, because that's really where they're getting a lateral view of the disc space, and that's where they really need to see well.
Dr. Ellozy, I have a question for you. Before you enter one of these cases, I know that you make sure that they have special instrumentation for you in case we do run into trouble. I was wondering if you could run through a few of your musts before you'll assist in one of these cases.
Sure. I think we always want to have vascular instruments and vascular clamps and appropriate needle drivers and everything. It tends to be a deep hole, especially if you're not making a large incision. And so when you do have to fix a vein, you want to have the right instruments. I think that I've adopted some instruments from the minimally invasive mitral valve set. I think it's called the Valvigate set by Aesculap. And so they've got a long needle driver, which is, it looks almost like a laparoscopic needle driver, but the handle it functions like a Castro. And I think it's it's probably about 30 centimeters long, or 25 centimeters long. And I've also adopted to using a laparoscopic knot pusher, because I think sometimes when you're trying to get around the iliolumbar vein and tie it so you can expose L4, L5, I wear size 8 gloves. It can be sometimes hard to get my fingers down into that space if you have a small incision. And the laparoscopic knot pusher allows you to see it all the way down, and you can use it with 5/0 prolines without breaking, and it's a really, I think, a nice addition when you're working in a hole. Do you have any special instruments you like on your tray? You have a long rider, right? That's what you like for those things?
Yeah, I have a long, I have a rider. I also have a long right angle clamp. These are really thoracic instruments that we're using in this approach. These are not short instruments, and I think you have to remember that. We all have specialized tray for these approaches. It's not something that you just bring in your vascular tray and it's going to be part of it. These are specially made up trays. Probably something you could even have a link to what our pick set is. Yeah.
There's one instrument that I've heard about, and I have not used it yet, but I'm very interested in getting it. And this is a friend of mine who's in Abu Dhabi, is working with a vascular surgeon out there who's at Cleveland Clinic, and it's basically a long handle and then a ring at 90 degrees from the handle. So if you get a hole in the vein, rather than having to get proximal and distal control and getting a clamp on it, you can just put it down on top of the hole, and it will circumferentially control the hole, but there's enough space so you can still sew within the middle of it. And I think that is nice because sometimes you get into the vein and you haven't done enough dissection that you can get proximal distal control enough to put a clamp on it circumferentially. So I would like to get my hands on this. If anybody hears this, they can send me one.
So Dr. Connolly, for the technical aspects of controlling the veins, for L5S1, we're dealing with our middle sacrals, and for the L4, L5 is the iliolumbar. Can you what is your kind of go-to approach for whether you bipolar or tie? How do you handle the vessels?
I think the vessels are best controlled with ties or clips. We like to burn through a lot of things, but I think they're best controlled with ties. That's for all vessels. One of the challenges at L4-5 is you're mobilizing the left common iliac artery to the patient's right if you're approaching it from the left side, and you also have to mobilize the left common iliac vein. And one of the tethering points for the left common iliac vein is that when it passes basically right behind the iliac artery, and the tether point is at ascending iliolumbar vein, and that's basically crossing posterior and cephalad behind all these structures, and so it actually ends up being a very deep vein. And so,
it's also very broad.
Yeah, and so
short and broad.
If you're not able to mobilize the vein to the patient's right enough to get good exposure for your L4-5 approach, a lot of the time you end up taking this vein, and again, that's best dealt with preemptively before you tear it.
And are you what do you tie it with?
Tie it with a 3/0 silk tie or a 2/0 silk tie if it's a larger vein. But generally, once these veins are devoid of blood, they cinch down and they're minuscule.
I'll usually put 2 ties on the iliac vein side, because what I do worry is when you put tension on it, you worry about sort of, even if it's fixed, when it's not under tension, popping the tie off. And so I'll often put 2 ties on that side, but that's probably the most nerve-wracking part of the case, is getting control of that vessel, I think.
How important is preoperative planning and seeing the imaging before these cases? And have you ever dealt with aberrant anatomies like double IVCs or something to that extent?
I have not seen any aberrant anatomy per se. I've seen a lot of reoperative surgery or surgery in prior surgical fields. I've dealt with endografts from an aortic aneurysm, and the take-home point for that is that the aorta is just very stiff, and it's not going to deflect like a normal aorta or iliac artery usually will. And so you can, again, trying to treat the expectations of the exposure are usually the most challenging parts.
Yeah, I think a duplicate IVC would be a luxury, because it usually goes up on both sides, and so that does all the work for you. But I think to Peter's point about managing the expectations of the spine surgeon, I think also having an understanding of their devices that they're comfortable with, because there are certain different subtleties in terms of the amount of exposure they need depending on the cage. There's some that have blades that go into the end plates above and below, so they need a little bit more anterior exposure. Some are a little wider. Some can be implanted. Some have to be implanted directly from the front. Some can be put in an oblique fashion, and so that determines how much exposure you need. And so having some sophistication with what they need can often make your life easier.
And we have an article from I believe it's the Journal of Spine Surgery that we'll put in our show notes for you guys to get they kind of cover all the approaches and give you a good background before entering these cases. So Dr. Ellozy, as a program director in vascular surgery, and you also train a lot of general surgeons, what is the importance of these cases today when we have a diminishing number of open abdominal cases?
I think, thank you for putting up that softball. I think it's a great tool for our fellows, just because you become comfortable in the retroperitoneum dissecting around the vessels. For me, it's kind of nice because the patients aren't heparinized, so it's a little bit, there's a little bit less mopping up to do afterwards. But I think it's a very good way to get open abdominal experience for our fellows. And now that we're not doing as many open aortic repairs as they were doing 25 years ago.
All right, and Dr. Connolly, we can't end this discussion without talking about massive bleeding from an iliac vein. What are your tips for listeners out there that maybe, there's many hospitals where people do this on their own and they might get called into that situation, let's say, rather than create it themselves. What tips do you have on controlling this?
I suppose one of the highlights of being a vascular surgeon is that we deal with bleeding in a number of ways, and it's not, and we're frequently called in to bail out our colleagues who've encountered either lack of blood flow or copious blood flow. And so part of, I guess, with regards to spine surgery, I think, you have to, if you do get into a significant amount of bleeding, I think the most important thing is to basically have a backup option. And when I say backup option, I mean, have a colleague who you could possibly call in and say, hey, I need some help here, because you can always hold a finger on there, and that's usually the easiest thing to do. But you also have to be able to control the vessel, and sometimes it needs more than one hand to do that. So, not being too prideful and knowing when to ask for help is probably the most important thing. I
think that's a general maxim for all surgery. I think that's really very valuable.
But that being said, I find the easiest ways to control an acute new bleed, especially on a vein, is I use a lot of peanuts to basically compress the blood vessel, and then obviously I usually use a 5-O-proline on either a long Castro or a long rider. And it's just knowing you have to be very delicate when you work with the vein, because they can tear easily. So that's another take-home point.
Thank you, Dr. Connolly, for the wise words on how to safely expose the spine. And now we will close out this episode with a few more questions for Dr. Albert and Dr. Qureshi. So, Dr. Albert, one thing that is becoming more aware in both general surgery and vascular surgery is the wear and tear of our jobs on us as surgeons. Do you guys see this in the orthopedic specialties? And if so, do you guys do anything to help prevent these injuries?
Yes. So there's a lot of awareness around radiation exposure. It's become more and more prominent in our field. And I know a number of surgeons that have died of radiation-related cancers, thyroid, throat, tongue cancer, all kinds of cancers. So it's become aware, and Dr. Qureshi is one of the leaders in this, looking at navigation to avoid use of radiation. That's one. That's not physical. The other thing is there are surgeons that we know of that when you use these big instruments, curettes, and doing a lot of you can imagine, you've seen our Kerisins, which are squeezing instruments. I have a friend who's actually had to be disabled because he had metacarpal phalangeal arthritis and literally couldn't operate, things like that. So we're always looking at ergonomic solutions. People who are deformity surgeons, where they put lots and lots of screws in, not doing it by hand, doing it under power. There's a lot of companies working on technologies to do that. And Dr. Qureshi can probably comment on other things that are being done in that way.
Yeah, I think, like Dr. Albert was mentioning, a lot of our job requires repetitive motion of joints while wearing either lead, which can be very heavy and add essentially, 20 to 30 pounds of weight onto you that you have to carry. Oftentimes we'll wear loops like you guys do as well. And so, having to look with your neck down, can put a significant amount of stress. Having to turn screws over and over again can affect your wrists, your shoulders. So there are a lot of these sort of degenerative wear and tear things that I think as spine surgeons in particular we're at risk for. So there has been technology advancements in that. Use of microscopes is much more popular now, so to help with your neck and not have to wear loops or a headlight. Doing three-dimensional imaging intraoperatively so you could avoid wearing lead is a big thing now. And then ultimately, it's one of the reasons why robotic surgery has become increasingly popular in what we do, because of the fact that it will hopefully reduce surgeon fatigue, which can not only have a negative impact on the surgeon, but also the patient.
Do you guys have any recommendations for any activities or exercise that can be protective of the spine, especially for a vascular surgeon who's rapidly approaching middle age if he hasn't already reached it?
I'm looking at both of you, all three of you, and the only person that looks fit is Kevin in the room and Dr. Qureshi. But so my recommendation is for really to protect your lumbar spine is core strengthening. There's three things: core abdominal strengthening, back extensor strengthening, and cardiovascular conditioning. Those three things, if you spend those three nickels, you're going to have the most minimal amount. You still are at risk to have back pain because 95% of all humans will have it at some point, but your episode will be less severe and your incidence will be less frequent. And then for your neck, there's things that Dr. Qureshi talked about, but also, again, keeping your neck muscles strong and cardiovascular conditioning.
One fun question we like to ask at the end of all of our interviews: is there any one thing that you know to be true that no one else agrees with you on?
That Dr. Qureshi is the best minimally invasive spine surgeon in the world.
No one else.
But I believe I know it to be true. I heard you say it, but I know it to be true.
Dr. Qureshi? Yeah.
That's a tough one. Well, I think so something that we know to be true that no one else would agree with is that I would say, having worked at a different institution where I didn't buy into the hype that Hospital for Special Surgery really is the best place for orthopedic surgery, we know it to be true, and other people may think it's hype.
Well, thank you guys so much. This will be very helpful for vascular surgeons nationwide.
Thank you for having us.
Thanks so much for having us.
That concludes this week's episode of Audible Bleeding. Please check our show notes for more information and papers on orthopedic spine surgery and how access surgeons can collaborate. This week's interviewers were myself, Kevin Canary, and Dr.Ellozy.